Sorry.
Hi guys, welcome to November Bladder Health Month, and I'm here. I'm Dr. Rena Malik. I'm from Maryland. I take care of patients in Baltimore, Maryland, and I'm here with Dr. Jamin Brambhatt and Dr. Sonia Bahlani. Why don't you guys introduce yourselves?
Great. Okay, I was waiting. My name is Dr. Sonia Bahlani, and I am a pelvic pain specialist based out of New York City. A lot of people don't know what that means, but I did my residency in GYN and then my fellowship in the Department of Urology.
My name is Dr. Jamin Brambhatt, or as my patients know me as Dr. B, or B for bladder for the purpose of this talk. And I'm a urologist in Orlando. So I basically work where everyone used to want to vacation before all this COVID stuff. But I went to school at the University of Boston University for undergrad and medical school. Then I trained for 5 years in Memphis, Tennessee. And then I did a fellowship in robotic microsurgery at the University of Florida. And I've been attending for about 7 years now here in Orlando, Florida.
This is so great. I love that we have people from all over, at least all over the East Coast, I guess. And we all kind of have different specialties that we focus in on, but we all are centered on, genitourinary health. And so we're going to talk tonight about kind of bladder health as well as men's health and talk about some pelvic pain. If you guys have questions, please make sure to comment them in the chat section and we'll try to get through them throughout. And I also have some questions that were asked of us during on Instagram that we'll answer as well. But November Bladder Health Month is really special because it's meant to create awareness for bladder issues. And there's also Movember, which is a specific part of the month, specific title to help raise awareness for prostate cancer as well. So we can start talking about the things that we kind of take care of. So I take care of what's called female pelvic medicine and reconstructive surgery, and take care of lots of kind of benign or non-cancerous urologic conditions like overactive bladder, urinary incontinence or bladder leakage, and kind of complex reconstruction.
And so to kind of stem off of that, I take care of a lot of patients who may have signs and symptoms of overactive bladder, but they may often have things like something called interstitial cystitis or bladder pain syndrome, pelvic floor dysfunction, and then integrating this into how for women, the vulva and the vagina plays a role. And for men, a term—
Are we allowed to say that on this?
Yes.
Is my mom watching?
That's anatomy. Mom, of course we are. And then for men, a term that we use called chronic prostatitis, but chronic pelvic pain syndrome. So it can occur in men as well.
So yes, I'm fellowship trained, but I would say 70% of what I do is still general urology. So I'm usually the guy that you're seeing when you first start having overactive bladder symptoms. Whether you're a male or a female. So I see both in my office because both can suffer from this. I think the reason we see more women is because they're more open about this problem, but it is something that can affect men and women of all different ages. So I'm the one that's usually seeing them in the office. Either they come on their own or they're referred by their primary care doctor. And so depending on where they are in the whole workup, we'll initiate a workup. And I know we're going to have some time to talk about that later, but the workup can be very simple or very complex, and the treatments can be very simple or very complex. It just kind of depends on where you are and how bad your symptoms overall are.
Yeah, for sure. I think that it's important to realize that if you have these symptoms, like you're having accidents or you're going to the bathroom a lot during the day or at nighttime, or if you're having pain or blood in the urine, things like that are really important for you to make an appointment and see your primary care doctor and potentially a urologist so we can help you with these symptoms. I think the biggest myth is that some of these things are just normal and that you have to live with them. Even in the pelvic pain arena, we think a lot of women think that sex should be painful, and that's not true. So I think all of these things are really important. And that's why we're here today, to kind of let you guys know more about that.
Yeah, I just wanted to say before we start the official stuff, like, you're absolutely right. Like, you should get yourself checked, because I, in the past week alone, have diagnosed someone with bladder cancer that just came in to see me because they were peeing more. We've diagnosed women with certain GYN cancers because they came and saw us with overactive bladder. We looked inside the bladder and they had all this stuff like growing inside of them. So absolutely, even though this is like only one out of let's say 1 out of 10 patients I see that we find these bad things, that person could be you. So don't take any of this stuff lightly. If you do have a change in your symptoms and it's not because you're drinking too much coffee or stressed out, definitely get yourself checked, because you'd be surprised like what crazy things we find in our office every single day.
And yeah, and for men, you may also find prostate cancer. So I think even if you're a man, don't be stoic and sit at home. Make sure you come and see us and get screened for prostate cancer, because that can absolutely be a cause of your symptoms.
And then also, in general, even if we're not talking about cancer, this is a quality of life issue. And that's what I tell all of my patients. Just because you have it, just because you pee 30 times a day, doesn't mean you have to, or that's normal. It doesn't mean there's not things we can do about it. So even if it's not cancer, there's so much stuff we could do to improve your quality of life.
All right, so why don't we start, guys, with the one thing that you wish all your patients knew about, like the big thing that people are always like shocked to hear about when you see them in your practice?
I wish most of my patients knew how much the pelvic floor actually played a role in bladder-based symptoms. So I think whenever someone comes in with urgency and frequency, we're so quick to just be like, it's bladder-based, when in fact, at least for the patients that I see, a vast majority, and for IC patients, almost 70% of them actually have concomitant pelvic floor dysfunction, which is the cause of their irritative voiding symptoms.
And can you tell people what IC is?
Sure. Interstitial cystitis or bladder pain syndrome, really, that term doesn't really mean anything. So people always come in and they're like, I've been diagnosed with this. What does this mean? Why does this happen? What we believe is there's some sort of disruption in what's called the GAG layer of the bladder, or the glycosaminoglycan layer. We don't really know why it occurs, but oftentimes it's secondary to chronic inflammation. People always think, like, we talk about cystoscopies and stuff like that, and almost 80% of patients with IC have normal cystoscopies. That doesn't necessarily mean that they don't have symptoms, or that they're not in pain, or they're not uncomfortable, but it just means that when we look inside, we don't necessarily find something that we can actually physically see.
You'd be surprised. I find so many patients that come and see me for IC follow-up, like they've lost their urologist or they've moved. And honestly, half the patients, I would say, don't even have IC. I mean, I do like a simple workup. And I don't know what your thoughts are, but I feel like once patients are diagnosed, they just get put in this like bubble, like this layer where they're kind of like all these like stigmas come into play, where I feel like sometimes we forget that we can still offer them some new things like neuromodulation or other things, and not just let them suffer and put them on medications that have a lot of side effects. But, I think I'm very cautious in labeling someone with IC. I don't know how quickly you guys like to do it, but that's like the last thing that I diagnose these patients with. If I diagnose, I'd rather put cystitis or chronic cystitis than IC, but that's just my opinion.
I'm the same way. I see so many people who've been labeled with IC or come in because they're concerned they have IC. And I don't really label someone with IC until we've ruled out pelvic floor dysfunction. And they can have concomitant pelvic floor dysfunction, but I at least want to treat that first and see if they improve before I label them with, a real disorder title name like IC.
And I think it's tough because IC gets such a bad rap. And I think it often gets a bad rap because a lot of clinicians don't know how to treat it. So I don't necessarily feel like the onus falls on the patient because they're given like a list of food and they're like, don't eat anything. You're going to have to suffer with pain, urinary frequency, and urgency for the rest of your life. And there's really nothing we can do. And I think that often in and of itself puts patients in this box and they're like, gosh, I just don't want this diagnosis. And then we look at medications like Elmeron, which really work in less than 20% of the population. If you even look at the data, now we know about retinopathy, hair loss, GI distress. So like you have all of these factors, but they're only given this one medication when there's tons of other things we can do prior to even getting there. You know what I mean? And prior to even getting to neuromodulation. So for sure, I see the hesitancy in diagnosing it, but I think part of that is also just because we don't know enough about it. And a lot of people don't know enough about how to treat it.
And honestly, that's why I think it's important that you find someone that specializes in this disorder. You can go see a general urologist, like you can come see me, and I know I would say 50% of what these two ladies know, but I'm open-minded. I would say there's some other physicians and my colleagues that are not. They'll just see IC and be like, oh man, like send that to the junior partner or the new person, because it's mentally and physically taxing. And so that's why if you have to travel an extra 10, 15 minutes, go ahead and travel. When you have some of these rare disorders that come with certain stigmatisms or something that you've been suffering with a long time, find an expert. Like just Google, some of these people's names or your symptoms, and you're going to find experts in this field. And I'm going to go off on a tangent. What about medical marijuana? I have patients that get medical marijuana for their IC or cystitis, and it's like a miracle. Now, I'm not here promoting it, but there's something to it. And I haven't really able to find the science. So I was going to ask you guys either now or later on, like what is the why? Like why does that work better than anything else they've taken their whole life?
For patients with IC, there are cannabis, and not just patients with IC. So for the general public, we all have cannabinoid receptors in the bladder, and that's been studied in rat models and shown. But the reason that we at least believe, I think, and Rena, you tell me if you think differently, but that we believe that medical marijuana even works for something like IC is because it works on the C afferent nociceptor fibers. And so that ultimately,
oh my gosh, like.
Yeah. It's coming back to you now, right?
I think I knew all this stuff when I took my board.
But that's the data behind it. And that's theoretically why it works. And then, obviously it depends on the amount of THC versus CBD, but like even at night. So for patients who have chronic nocturia, it's helpful to add a little more THC to their regimen so that they're not waking up all night. Because you think about it, when some of these patients are waking up all night, they wake up in the morning and they're like zombies, and they're not able to function. And then that ultimately cycles into that quality of life thing that we're seeing so much, or the inability to have chai or have coffee because it's going to bother their bladder. And ultimately that affects their quality of life as well. So that's key. Yes. And it does. The studies are still out there, but I agree with you. There is something to it, to medical marijuana.
I agree with you. I don't use it a ton, but I do agree that there is value in it. I think also it works as kind of like relaxes the pelvic floor. Like it works on the pelvic floor and helps with people who have like refractory pelvic floor dysfunction. So I'll use it in those patients as well. I try to use it. I talked to like the dispensaries here and I learned how to make a suppository because they don't sell them in Maryland. So I give my patients like the recipe and I'm like, here you go. And, you can go ahead and try it in the right circumstances, obviously.
But what I think is key about all this is thinking outside of the box and that's like to your point, Dr. Jamin, Dr. V, where you said a lot of people are not even wanting to discuss this. And so sometimes you're the one urologist that'll say, okay, maybe this is a tougher topic, but let's delve into it a little bit more. So I agree with you, Rena. We might not have all the data, but we certainly have different avenues to try to treat these patients that work.
So this is like the complex, but like you guys are such a wealth of knowledge. Like what about like the basic overactive bladder? Because I saw some of the stuff you guys have been posting. Like one thing Rena posted is like, don't just go to the bathroom every time you think you have to go. I actually tell my patients to do that. But it's most of my male patients that have gone through pelvic floor rehab or have incontinence issues or like overflow incontinence, which basically means like their bladder is so full all the time they're leaking. But you mentioned something different, which is interesting because I have tons of nurses I see that used to be nurses. Now they have overactive bladder because they said they held their bladder for too long. So I'm just curious, like, what is the science behind it? And is there something I should change in what I'm saying? So
I think it depends on the reason that they're there. So if they're there for like holding their urine, like the nurses, the teachers, the doctors who never get to go to the bathroom because they're too busy and you've been holding your urine for like years.
I just wear a catheter all day. So
you're like,
you guys don't do that?
Bladder help on.
so
I
get all these catheter samples. So I just, it's like, all right, long
leg bag as we're speaking. So it's all good.
I not only prescribe catheters, but I also wear one. This is the last time I've been invited on this show. So.
On a tangent, my residents were just talking about how they think that they should all have to put in catheters on themselves before they graduate. And I was like, why? Why? Anyways, so I think it depends on the person. So if they're holding their urine for like years and years and years, like those dysfunctional avoiders who don't pee at all during school, or they, hairdressers, teachers, nurses, doctors, they need to go on a timed schedule so they don't forget to go, because over time they will stretch those muscle fibers and they will weaken their contraction and make it more difficult to empty. And so, like you'll have random patients who come into your office for overactive bladder, and you'll do a bladder scan on them, which checks how much urine is left in their bladder after they urinate. And it'll be like 300 cc's or like 10 ounces. And you're like, whoa, like I didn't expect that. So I think those are that people. And then for other people, I think, if you get into a habit of avoiding just in case, and you're an overactive bladder person, over time, you're like recalibrating your brain and your bladder that, hey, this is actually what full should be for me. And so you start sensing the really strong urge to go at a much less full bladder. And then you'll have to go more. And that this self-perpetuating cycle of overactive bladder.
I totally agree. I mean, I do this even in my patients with interstitial cystitis, because they get that sense of urgency probably when their bladder is not as full. And bladder retraining is really key for them to kind of disassociate that feeling of a slight fullness to urinate.
So I was going to show everyone this. So this is why you shouldn't hold your bladder. So this is a bladder. So I never answered the question, but what is the one thing that you would tell your patients they don't know? It's your bladder is actually a muscle. So just like the rest of your body can get certain types of muscle fatigue, or certain things in your body can do to kind of like get those bigger muscles, you can actually make your bladder work better for you. So my kids told me to use this today. So this is a balloon right here. So as you can see, this is how your bladder actually stretches. And then when you empty, it slowly will go away. But if you kept your bladder full all the time, it's gonna become what we call like a floppy bladder, where it's gonna kind of stay stretched out and the muscles are gonna stay stretched out. So you're not gonna be able to empty. So what you wanna do is always have like the healthiest balloon or the healthiest bladder. And for men, like you are like going against a mountain as you get older, and that mountain is your prostate. So yes, I'm not turning into genders, you're a male versus female, but having the prostate in a male definitely makes things a little bit harder when you go pee. But in the same token, being a female, you are also more prone to infections because the urethras are shorter. So every pro has a con, and vice versa in the genders. But do you think it's a good way to kind of explain it, or is there like a better way? Because a lot of my patients don't even know where the bladder is. They're like, oh, the bladder's right there. Oh, it's connected to the urethra. Oh my God. Like, it's just, so we kind of try to use props as best we can, because it's hard to kind of use my hands.
I totally agree. There was a study that was done where they showed a picture of like anatomy, and I think only 60% of people could point to their bladder, like prostate, and actually the penis, it was like 89%. And I was like, what? This is, obviously it was probably
wait, 10% of people didn't know where it was?
At least on the picture.
That's awesome.
But Jamin, I wanted to ask you more. So I know you do a lot of men's health, specifically testicular pain. And so what is, how that's like a really complex issue and a really challenging one. What is something that you tell men, or like, what are some first line things that you tell people who have testicular pain, like how to manage that?
Well, first is the general legal spiel, which is, hey, if you have pain that's abnormal and it's abrupt and et cetera, then go to the emergency room, because it could be testicular torsion. So we have like a twisted nut. But the most patients I see are the ones that are labeled as chronic. So these are individuals that have had chronic pain in their testicles or their groin or their pelvic area for over 3 months. Most of the patients have been through many different doctors. They've been through anti-inflammatory therapy. A lot of them have been through physical therapy. They've been through antibiotic therapy. They've ruled out prostatitis, et cetera, and then they still got this pain. And so my partner actually started all this research, and then I joined him as a fellow, and then we've been working on this for years now. And that's because 100,000 men a year, there's an incidence of 100,000 men a year that have chronic testicular pain or chronic orcalgia. We looked at our research, and on average, before the patients see us, they've been to 7 different doctors. They've tried multiple medications. Half of them are hooked on different types of narcotics. Like, they've had surgeries and procedures and testicles removed. And honestly, like, what most of these patients need is someone just to listen. And when you start listening to, like, okay, this is how it happened, and then based on our experience, we were able to create an algorithm where we try to preserve the organ. And the algorithm is very simple. If you haven't tried the medical stuff, the conservative stuff, then we'll try it. If not, I actually have a new step in mind is why I try different supplements, because there's lots of supplements with cannabinoids. There's supplements with rye and quercetin and all these things that hey, let's try this before we take it to the next step. The next step may involve either injections and medications or something called neurolysis, where we do nerve strippings, we even do freezing, we do Botox. There's lots of exotic things that we can do, but honestly, like if I can get that person to not have to go through all those exotic things, then I'm winning at the end of the day, because I was able to try natural things. And so that's very important, is again, to find someone that deals with this on a daily basis, because you don't want to get sucked into getting your ball taken out, because you're still probably going to have pain. There's something called phantom pain that you can still have. And if you're young and you're in your fertility days, like, do you really want to go through all those procedures? I wouldn't recommend it. And most of our patients don't have to, but that's because we kind of listen and we have this experience, which not everyone else does. Doesn't make us better. It just means we have the experience.
Do you ever find the testicular pain can be related to the pelvic floor in any of the patients that you see?
Absolutely. It absolutely is. And so we always recommend our patients go and get some form of trigger point therapy or pelvic floor therapy. The thing in our areas, there's very few places that they can go to do it. And there are some places which are cash pay. Now you can imagine, like, if you're seeing a veteran that finally got in to come see me, and then I'm recommending pelvic floor therapy, like, you don't even know where they're going to have to end up going. So I think some of the barriers, it's not easily available or accessible, but absolutely, there definitely is a component to it. And that's why now there's a paper I just saw in one of the journals where they recommend getting an MRI on a lot of these patients before we do anything, because there is some instability within the pelvis that could be leading up to this. But the problem with all that instability is it's very hard to fix. Mm-hmm. What we focus on is, like, how can we blunt the nerves that go down into those areas? Because they're not going to affect their sex life. They're not going to affect, the only thing it's going to affect is like the sensation in the groin and the testicle. So there's no really long-term repercussions. So that's what we try to focus on, is like getting that nerve to just fire not as strong. Because to get someone to fix all those abnormalities or find an expert, I personally feel is extremely difficult. But again, I may be living in a bubble, and I'd love to hear y'all's insight on that.
I think you're absolutely correct. I mean, I see a few men like with testicular pain, and just like you said, I think it's multifactorial in nature, often neuromuscular. It's interesting because, like, where I trained, we do like a lot of, tricyclic antidepressants and stuff like that, just to kind of calm the nerves down, like you said. But often it becomes this thing where it can recur, or where it goes up and down. So they're good for a little while and then it comes right back. And then even doing things like spermatic cord blocks, like you said, how long does that last for, right? So I think seeing a specialist like you who's able to give them long-term relief with some of these other modalities that may be new but promising is really key, because for the patients that I've seen, it's really debilitating. You know what I mean? It's one of those things where they just can't function.
What's interesting you mentioned is, I think a lot of patients are disappointed in their care when it comes to these chronic conditions, is because we overpromise things. And what I realized in the past, I would say year and a half, I've kind of shifted the way I start with my patients. I'm like, listen, I'm not God. You're never going to be 100% pain-free. But I'm here is I'm going to offer you 100% effort. But you have to mentally be prepared to always be in some sort of pain. But if I can make you forget me, that's what I want to try to achieve. And, I don't have any studies where I look at things, but I've had, I would say, better satisfaction scores in the surveys these patients get, because I'm just honest. And I felt like maybe when I was starting off, I was a little bit too zealous and over promising things, or a lot of the doctors they went to promised them the world and then they were disappointed. But I think setting expectations helps. Even I think you mentioned with IC, I think that's why we're a little bit different, is I'm just very honest, like, yo, I ain't gonna be able to cure everything, man.
Yeah, I mean, I think it's the same thing for OAB. Like, I tell all my OAB patients, this is going to be an ongoing process. I can get you better. That'll be the goal, to get you better. Will I get you dry? Will I get you completely happy? I mean, I'd be so happy if I could, but this is an ongoing process, it's a chronic disease, and we have to work together on it. So I think that's totally, totally valid.
Can I ask you guys a random question, since all the kids are probably asleep right now? But I just had a patient recently come in, female, that has major incontinence, like when she's climaxing. And I sent her to like our female urologist, but like, I was like, is there something I can offer her to avoid it that's medication wise? Because I was like, I can't give Flomax. I think it'll get worse. I can give you OAB medications, but is that really going to help? Like, I was just curious, like, before I send them to someone like you, like, what is it something I can do? Because I think I've seen 2 in my whole career, but, it was kind of like, damn, I wish I knew what else I could do for them, before, and, without having to refer them out, or at least trying something before I refer them out.
I mean, first things first, I would say we have to make the diagnosis, because just like you said, a lot of people will say, I'm having incontinence during climax, when actually they're just having a female orgasm. And so one thing that you can do is actually tell that patient to take azo right before sex. And then if she actually, her sheets become orange, then sure, in fact, she is having incontinence. If she's not, then she's just having a female orgasm. And there's a big difference between the two, because we know that, they're treated differently. And Rena, I'm sure, can speak more to the incontinence part of it, in terms of if it was too much discharge where she felt like she was just too lubricated during climax and that was bothering her. Often you can look at things like SSRIs or SNRIs that decrease lubrication, but they come with their own set of caveats, just like you said, with expectations, because often that can affect their climax. So I think it's a, back and forth, but first things first would be to make sure that she is actually having incontinence during that time.
Yeah, I completely agree. I think, first of all, having very lubricated vaginas or having female orgasm is completely normal. But you're right. A lot of women don't realize, sometimes they'll go through phases in their cycle that are more heavy with lubrication than others, a physiologic discharge. And so they feel like this is something that needs to be treated. So it is important to check. And then climacturia is technically stress incontinence. So incontinence with stress, basically. And so you treat it as such, and there's no medication for that, but they could try pelvic floor physical therapy or, or other options if that doesn't work. But I would probably start conservatively in something like that.
Rena, if you had to do, if they also had SUI in other circumstances, like, coughing or whatever else, and it was really bothersome, they were going through multiple pads and you had to operate on them, if you had to do a sling, would a sling help that ever?
I don't know the data on that, to be quite honest with you. If I had a patient like that, I would look it up, because I don't know. It should, in theory, because it is stress incontinence. And so it should help in that regard. But if that was the only symptom, I definitely would discourage them from having a surgery and encourage them to do pelvic floor physical therapy.
Yeah. But that was something that I've been thinking about. And you're right. I bet there's not even a ton of data on it, because it's just, you probably don't have enough patients to study it, but interesting.
So I guess my one thing that I want
me on this R-rated topic. Thank you.
So I guess my one thing that I would want patients to know is that when you think you have a UTI, it's not always a UTI. So I get a lot of recurrent urinary tract infection patients, and they've never been truly studied. They just get urethral pain, what's called dysuria, or pain with urination, that goes away, or that, they take antibiotics and it goes away. But it's never been checked if they truly have positive urine cultures, and they could be masking a whole bunch of other disorders like pelvic floor dysfunction, like interstitial cystitis, that can be treated with other medications without antibiotics. And so I think it's super important for patients to realize that and get urine cultures when they have those symptoms.
Yeah. I mean, I don't know about you guys. I do a lot because especially during COVID, a lot of my patients couldn't come in the office in the middle of New York City. I'll do a lot of self-therapy protocols. So where I'll give them a script for a urinalysis, urine culture, and then I'll say, but you cannot take anything until you drop off the culture. And it's often just been helpful in this day and age, because I completely agree with you, Rena. I will not give antibiotics if it's not culture proven, but at the same time, they often just need that reassurance. And so, key.
Yeah, I do that all the time. I give all my patients 3 urine culture orders, and I say, drop your urine culture off, send me a message. As soon as it comes back, I'll send you antibiotics if it's positive.
I just told them to call my nurse practitioner.
That sounds nice.
actually, you'd be surprised. I do take my time to get all these people off antibiotics. I tell them, I'm not one that's going to order your antibiotics. I have gotten some bad survey scores because of that, but I want to get them off this vicious cycle of just medication, especially since we're becoming so resistant. And then I'm seeing a lot more patients with side effects, especially to the sulfa medications. Like, we got to get you off it. And what I realized, a lot of these patients with recurrent UTI end up just having simple overactive bladder. So trying something like medications or Botox or neuromodulation or axonics or one of these therapies, like I'm like just amazed at how well these things work. Just kind of taking a outside the box approach, and plus cranberry supplements. Like, I love giving them out. I'm not paid by any of the supplement companies, but I just love. I think it's a game changer. I mean, I know it's been around for a while, but I think more and more patients are seeing the positive benefits of it. So
I'll say I am not a huge fan of cranberry supplements, only because
really,
patients will flare from them. I mean, they just can't tolerate them as well. But I will say that one thing for women that I think is so important that we don't discuss is the role of estrogen and testosterone within the vagina and the vestibule that can contribute to recurrent urinary tract infections. So, I mean, we're talking about perimenopausal, postmenopausal women. I mean, this is now AUA guidelines, you know what I mean? And it's like real, like, first line therapy for women with recurrent UTI so that they don't end up on all these antibiotics all the time. So my thing is always like, examine the vestibule, examine the vagina in women, because more often than not, they can benefit from topical estrogen therapy, which does not increase their risk for breast cancer, which is key because it's a question that we always get to.
so what would you recommend? Because aren't some of these esterase creams made from like horse balls? Like what? Like
Yes,
what are some of the
yes,
options
yes.
for this? To be honest with you, like,
So there's tons. So I always
and I
tell my
know the answer
patients.
to this question. I'm just asking for discussion
No,
purposes.
I know. I like to. I
And
like to.
ABU, please don't look at me like I don't know what's going on.
How do you not know? And Rena, I'm going to let you take over. But what I always tell patients is like, the best medication is one that you're actually going to use. The best topical estrogen therapy is one that you're going to actually stick with, because for some of these patients, you can use them twice a week for infinitum. You know what I mean? And so you want, whether it's a cream, a ring, or whatever, it's just something they're going to stick to.
Yeah, exactly. I can't tell you how many people come to my office who are perimenopausal, postmenopausal, have been having true recurrent UTIs and have never been told about estrogen, which just boggles my mind. This needs to be in our urology armamentarium for sure. But I don't want to take up all the discussion about recurrent UTIs because we do so much more than that. So Dr. B, tell us a little more about prostate health, since it's Movember as well.
Oh, hey, but listen, what else can you give? Is it just the estrogen cream, or?
Oh no, you can give, so there's E-string, right? There's like rings that you can give. There's also what's it called? It's like a little suppository. What's the name of it, Sonia? I'm forgetting the name right now. Imvexy.
Imvexy, Intrarosa. And then my personal fan favorite is actually an estrogen testosterone compound, because it's been studied in the vestibule. There's 70% more androgen receptors than even estrogen. So if you're not saturating the androgen receptors, just the local topical estrogen doesn't have as favorable of an effect. So, I mean, I think if we want to stay really current, using a compounded estrogen testosterone cream would be one of the most beneficial.
I'm gonna ask you guys a question because I don't know the answer to this, but I had a patient whose husband was like, "Whoa, I don't want her to be on this cream because I'm gonna get estrogen in my body." Like, is that true? Like, are they supposed to wait?
No, I mean, I will tell patients that they can wait 30 minutes just to help them feel better about it. But there's data on systemic absorption for topical estrogens, and it's really, really minimal. So, I do have patients who ask me, like, can I have oral sex after I put on a topical estrogen cream? And I will just say, wait 30 minutes, but there's really no data behind that. What do you say, Rena?
Yeah, I mean, actually, no one's ever asked me that, because to be honest, a lot of these patients are so miserable. They're not having a lot of intercourse, but because they're just so uncomfortable down there all the time from these recurrent infections. And so we need to get them clear so they can get back to having intercourse. That's part of the goals.
No, but this is actually very important with someone like me, because I deal with a lot of male sexual dysfunction. So I do a lot of penile injection treatments and vacuum pumps and penile prosthetics. And I always sit down with them and say, hey, listen, you're ready for this. Who are you getting this for? And once they get past that, like, a lot of their partners do have issues. So, like, this is great. This gives me an opportunity to, like, either refer them to someone like you guys, or actually see them as patients and try. Because, once that implant is healed in, 6 to 8 weeks, like, I don't want the partner to suffer, right? So I think this is great, and I appreciate you guys taking the time to discuss this with me. That's why I was asked, is like, well, like, it takes two to tango. I can only help one. What can I do for the other one? So thank you for that. So,
And you can help the other one because it takes 6 to 8 weeks for this stuff to start working. So you
oh,
definitely
really?
want to be
Okay.
getting started like when you're getting started with the partner for sure.
No.
Yeah, exactly. I tell some women that if they're really, really miserable and they have proven recurrent infections with cultures, I'll actually put them on a low dose antibiotic for that 6 weeks so that it can really get absorbed into the vaginal epithelium and actually change the pH. And that's how it works. It changes the pH of the vagina so that it prevents infections. And so that's what I tell them.
Well, this is a game changer for me, so thank you. So, you mentioned the prostate. Okay, now back to a boring subject here. Okay, what was the question?
Well, let's just talk about just general prostate
Yeah.
health. What do men need to know?
So you mentioned November, right? So I did not grow a mustache this year, and I usually have to end up shaving if I'm wearing an N95 mask. But I usually try to do a mustache, and the mustache is part of November. There's many organizations using the month of November to promote men's health. November deals with testicular cancer, it deals with like movement and weight loss, but most importantly, it deals with prostate health. I think what men need to realize about prostates is three things. Number one is there's a risk of cancer, so you should start getting screened. And cancer screening for prostate is super confusing. Is it 40 or is it 45? Is it 50? Just keep it simple, buddy. Like at the age of 40, start talking to your doctor. If you don't have a doctor, then heck, get a doctor. And if you have a loved one, if there's women watching here, if your man is approaching 40, it's time to start the conversation about overall health and prostate health. If you haven't had a PSA, which is a blood test to screen for prostate cancer, you should have one by the age of 50. I know there's some controversy based on guidelines, but just keep it simple. 40, start the conversation. 50, if you haven't had one, it's a little bit too late. To be honest with you, like rectal exams, that's why a lot of guys stay away from us. Like you don't always have to have one. I mean, I try to promote it. You don't have to. There's other things we can do, like keeping track of PSAs. There's other tests. There's also now really cool things we can do with technology like MRIs to really look at the prostate. So prostate cancer screening is not that hard these days. Number two, any treatment for prostate cancer, for enlarged prostate. So as you get older, your prostate gets bigger. It gets harder for your bladder to push. Any treatment for prostate cancer is going to affect your sex life somehow, whether it's Flomax, which can affect your ejaculation, finasteride, or the shrinking ones that can affect your libido, and surgeries which can affect your erections. So really your goal should be to have a very healthy prostate, and that starts at a young age. And that's where I get to number three. Everything that can cause you to have bad diabetes in the future, bad blood pressure in the future, bad cholesterol in the future, is also going to affect the health of your prostate. So that's why it's very important to stay away from that fast food diet, eat clean, eat green when you're young, because you're going to have a lot less of those effects of enlarged prostate. That's not me just saying it, that's research proven.
Yes, absolutely. Screening is important, and 100% get screened. At least talk to your doctor. You can decide if you want to proceed with screening after you have a discussion with your doctor about it. But if you have a family history of prostate cancer, if you're African American, if you have some genetic susceptibility, like you have a family history of breast cancer, you may need to get screened earlier. So make sure if you fall into those categories, talk to your doctor. All right. So I have a question, guys. I think we're going to go there since this is YouTube, and we might as well just talk a little bit about this. I get a lot of questions about the frequency of masturbation. Like what's too much? What's too little? Is withholding bad? Is there a certain frequency? And to be honest, I haven't done the research yet. I know what we kind of tell people, but I want to know what you guys tell people.
It's very interesting because I just got a media request, which is due tonight. This must be some viral topic, which I'm supposed to answer with those exact questions. I don't know if you got the
Rena.
same.
Getting at you from all angles. No, I'm just kidding. It wasn't me.
So listen, I'll go first on this one because I end up seeing a lot of patients because I deal with chronic penile pain. It's usually young dudes, 18, 20, 24, and they come with really bad penile pain, and no one can figure out why. And then they get sent by their other urologist or their primary care. And then no one has even asked them how much are they masturbating. And it turns out a lot of these dudes are hooked on masturbation. They're hooked on porn. So I have to have that really frank discussion with them. And eventually I get it out of them. And most of these patients I end up seeing get better just when I tell them to start limiting the amount of masturbation. I don't think there's a right or wrong amount of masturbation or ejaculation. I know if you ejaculate a lot more, it prevents your risk of prostate cancer. Now you'd have to ejaculate a lot for that risk factor to be improved. But I don't think there's any right or wrong. It's whatever pleasures you. But there is something where if you do too much, and I certainly think if you're doing too much while watching adult films or pornography, it's not only going to physically damage you, but you're going to be emotionally scarred as well. Because I end up seeing a lot of patients then in their 30s, or when they start having sex, are very unhappy with sex. And that's because they have these like unrealistic expectations on how sex is supposed to be, how sex is supposed to feel, how big they're supposed to be, how much she's supposed to enjoy, what all the orifices are and what they can explore. The reality is like sex is not as exciting as it looks like in adult films. It sucks if you over masturbate because of porn, and then when you start having relationships, it definitely affects it. So I think it comes down to not the frequency, but like what they're using to get excited. But that's just my opinion as a man urologist here that sees a lot of these guys in the office. So.
Yeah, no, I agree. When I was training, I remember there was a guy there was men who were kind of wound up and didn't masturbate frequently or at all for like long periods of time, and they would have pain and they would like write a script, like masturbate twice a week. I don't know if there's any like value to that, but I think it may help with stress and anxiety in those patients, which may be contributing to the pain.
Yeah, I mean, that's the context in which I've seen is a lot of patients, because a lot of patients, men with chronic prostatitis and chronic pelvic floor dysfunction, will complain of pain after ejaculation. And oftentimes it's because of the spasming of the pelvic floor muscles that occurs. And so same thing, Rena, when I trained in my fellowship, I would see the guys always write, masturbate twice a week, doctor's orders, make sure you do it, and then you have these like ultra conservative men be like, oh, okay, so it's okay. And the way that I think of it is that oftentimes when you give someone that path, which is a completely different situation than you're talking about, Jamin. So it's more of like for the patients who have pain, it's almost like this pass, and they don't hold that tension within their pelvic floor. So masturbation actually feels like a release, and that post-ejaculatory pain settles. So, I mean, it's just two different patient populations. So the answer is it's individualized, right, for each of these guys.
There is such a thing as blue balls, like that science proven. I know it gets like a bad rap, but it's true. Like you have to, because you're all these ducts inside of you get congested, and then there has to be a release. And obviously there's a natural release, but it's a lot slower. So if you're able to kind of get it out or come out faster, is that a good way to say it? Hey, but that brings up a great point. What about tamsulosin or alpha blockers? I haven't had really good results with them, but I end up seeing a lot of patients on it for this purpose. I just wanted to kind of hear your clinical opinion on it.
For pelvic floor dysfunction or pelvic pain?
Or ejaculatory pain.
Yeah, I've been told to give that as well as like, just in conversation, be like, oh, try it. Yeah. I don't know if it really helps. I don't, I guess the science behind it is relaxing the smooth muscle. And so maybe it's allowing the flow to, I don't really know, actually.
I find
it's just that something I think it's like handed down from attending to a resident. Sorry, go ahead.
Well, I think in theory, I mean, it makes sense, right? To relax the bladder neck so that they don't have these symptoms of post-ejaculatory pain. But truthfully, for some of my guys, the retrograde ejaculation totally throws them off, and then it freaks them out more. I think Valium suppositories in these patients work really great, to be honest with you, because it helps to relax the pelvic floor muscles and they don't get that spasming after ejaculation. But yeah, I mean, I think that a lot of guys get freaked out by retrograde ejaculation. At least a lot of my patients have, and they've been like, well, now I don't know if it's working. And then also it takes 6 to 8 weeks to really reach its full effect, so it's like it's not immediate for them.
So you mentioned Valium, but I've never prescribed that, but I see a lot of these patients. Like when would you give something like that?
Oof, well, it depends on the context. So for men who have a lot of urgency, frequency, and then kind of like what Rena was saying, when the bladder contracts, the pelvic floor doesn't fully relax, so they don't completely empty. So they have all of these irritative voiding symptoms. I think a Valium suppository works really great. The data for it is really in conjunction with pelvic floor PT. So like you said, I would send them to a pelvic floor physical therapist. And the reason that a lot of this is not covered, truthfully, is because insurance doesn't recognize pain as a thing. Do you know what I mean? So insurance is like, oh, you're just having pain with ejaculation. That's not a real thing. We're not going to pay for someone to treat that. Do you know what I mean? And so, yeah,
But they'll pay for your penile implant.
Right, exactly. But think about women with sexual dysfunction, nothing is covered. I mean, these medications are $400 a month for something that's been out for men for years. So, I mean, there's a huge discrepancy, but Valium suppositories work really well for that type of a patient. So irritative voiding symptoms in the setting of pelvic floor dysfunction, but ultimately they have a half-life, right? You're not going to have someone on it forever. So you want to make sure that you're actually getting those bladder retraining, pelvic floor relaxation techniques in.
So I use baclofen suppositories without Valium, just because I think that there is some systemic absorption of the Valium, but I still think that it's a great option to use Valium or baclofen. They do both work pretty well.
Cool.
This is like CME, guys.
Hey, are we gonna have time to talk about neuromodulation, man? Like, because I do a lot of it, especially when my patients diagnosed with IC, and it works. It's amazing. I find it to be a game changer, but it's hard to get people to really talk about it because. If we have time, I'd love to hear your thoughts on that because it is Bladder Health Month. So. Yeah.
So sacral neuromodulation in general is taking the nerves that go to the bladder and pelvic floor and stimulating them to restore normal function. And I do use it for overactive bladder, and I've used it for patients who have overactive bladder symptoms with pain, like interstitial cystitis, as long as they have the overactive bladder symptoms. It's also used for fecal incontinence and non-obstructive urinary retention. But I would guess that Sonia is probably the one who's used it the most for pelvic pain disorders. So maybe you can shed some light on that.
I actually totally agree with you. I use it a lot for patients whose primary complaints are urgency and frequency, and whether they have a component of pain in that or not. And oftentimes it does help the pain. For patients with pure pain, I often find that it's not so helpful. And that I mean, Jamin, I'm sure you can talk more about this. In the past, they've been also reluctant because if they have pain and lower back issues, and they have an interstimen and they can't get MRIs, it really upsets them. I know that's not the case now with the advent of the new technology, but oftentimes that was a factor for them in the past. But I think it works best for urgency, frequency, and sure, plus or minus pain.
Yeah, I think in my case, like a lot of my men like get ignored in the whole process, I think, because they just don't. And then, I think Botox is good, or botulinum toxin, but it has to be a recurrent thing. So I've been doing a lot more neuromodulation, and I would say with the advent of Axonics and the ability to get an MRI, all different Teslas of MRIs, and the rechargeability, I think patients also love new technology. And I'm not paid by any of these companies. I have zero disclaimers. I just think it's cool how new technology comes about and patients start coming out of the woods for treatments because they've been waiting for this stuff. I have so many patients that just couldn't get any treatments like this because of the MRI issue. And then now both major players, Axonics and Medtronics, have something for these patients. So I think it's awesome to have that innovation. I think it's really cool. I think the biggest issue I have is like, I say, oh, it's a pacemaker for the bladder, it's this and that. And sometimes patients just don't get it. And then some of them I end up getting urodynamics on all this stuff and they just get overwhelmed. Like, is there like a better way for me to pitch this to them?
Well, I do a lot of this now too. And I would say that I tell people it's a staged procedure. The great part about it is you get this trial period. I do a lot of PNEs, or peripheral nerve evaluations, where we place a temporary lead alongside the nerve root that goes to the bladder. And so you don't need to get sedated. You don't need to go to the operating room. You come to the clinic, we do it there. We place the temporary lead, you wear it for a week. And if it works, you go on to have the implanted device. And if not, you're done and you've tried it at least. So I think that helps pitch it. And then for the non-obstructive urinary retention, so people who can't pee, and it's not because they're blocked off by their prostate, for those people, they want to try. So I'll do them as stage 1 because I want them to have a longer trial period, which is 2 weeks. So that is in the operating room where you actually place the permanent lead and you have an extension that you wear on the outside for 2 weeks. And so for those patients, they are just willing to try because they don't want to have to catheterize anymore or use a tube to empty their bladder.
And how is it working for those patients, like with patients with like neurogenic bladders, essentially?
So I don't use it for, it depends on the neurogenic reason. So I've used it for diabetics. I've used it, long-term diabetics, patients who may have like really prolonged pelvic floor dysfunction and they're like kind of now no longer urinating. And those people have done, or like neurogenic etiologies, which I don't really know why, like it may have had some partial back injury. For those I've used them and they've almost all of them have converted to get the implant. But I think it's all down to patient selection. I haven't done it on a lot of multiple sclerosis patients or Parkinson's patients yet, but now that they're MRI compatible, I think it's more reasonable to do that.
What I found is in those patients that you mentioned, the MS, Parkinson's patients, it works great. But as their cognition and dementia and Parkinson's and everything declines, you're going to see it's not going to work as effectively. So they're going to still have to use those things. So how I tell my patients, it's a quality of life improvement. Even if it's for a year or 3 years, it's a quality of life improvement. If I can get you without a catheter, one less infection, it's worth it. And plus, trying it now when you're healthier and you can get through the anesthesia, whether it's local or IV or general, it's much better. But I found there's some like forums on neuromodulation, and it's so cool. Like one of my patients was miserable. She's a teacher. She stopped running because of her overactive bladder. And then she posted like this picture of running her first 5K again. And it's just cool, right? I wish they would like tell me these cool stories, because then I would feel much better on the days I'm getting yelled at by all my patients for being late. But it's so awesome. Like they can get these people to not think about you. And that's the cool thing about technologies is like it really can get you back in the game and back to living your life. And so you should utilize them. I don't think you should be afraid of them because what's the worst that can happen? As you mentioned, right? It doesn't work. It doesn't work. I don't think we really affected anything.
Yeah, so just for the people watching, overactive bladder can be treated by conservative measures, by medications. And if those things fail, we have these things called third line therapies, which include this neuromodulation, which is a bladder pacemaker. You can also do kind of what's called PTNS. So it's kind of an acupuncture needle that you put in your ankle. That's a little time intensive. You have to come to the office every week for 12 weeks and then once a month thereafter if it works. Or you can get Botox injections into the bladder, which usually are done about every 6 to 9 months, that will help your overactive bladder symptoms. And all these things are available to you so you don't have to suffer with overactive bladder. I mean, as you can see, we are super happy when you guys get better. And that's our goal, is to make you guys better.
And as a caveat, you can also do Botox into the pelvic floor, although off-label, soon to be on-label.
Hey, let me ask you a question. What about dehydration? Because I have patients that have overactive bladder because they're dehydrated. And then they ask me to like explain why. And I'm like, well, the urine's more concentrated. That's why it smells. You guys see that as well? Like, I just want to drink more water, but then they're like, well, I'm going to have to go to the bathroom more. So out of curiosity, like, what is your pitch for that?
Yeah, I just explained that like it's more concentrated, so it's more irritative to the bladder lining, which makes your bladder contract more or squeeze more often. So you get that urge more often. So if you drink more, you'll dilute that really strong urine, and then you'll be able to pee without having that urge so quickly or so frequently. You're right. It's hard to convince them, but giving voiding diaries is, I think, underutilized. Like I make people write down how much they're drinking and what their symptoms are, and see, like, it's kind of a learning experience for them too. They're like, oh, I drank apple juice and I peed like 4 times versus I drank water and I peed 1.
Same. I didn't know if it was my, yes, no, I do the same thing. I agree. I say the same spiel that you do, Rena. I don't know. I guess we have similar schools of thought, but yeah, that's absolutely true.
None of us have had to go to the bathroom yet, so.
Well, it's only been an hour, so I hope.
Well, no, we see see that coffee you have in your hands.
I wanted to be energized for this conversation today. You know what's every time I have to give a speech or something, or go on camera or something, I have to go pee. I don't know if it's habit or what. Like, I don't drink anything. I don't have any coffee, but I still have to go pee. I don't know why it is.
It's your pelvic floor.
Wait, can you prescribe me Valiums?
And pelvic floor PT. I'll give you a wand. Go for it.
Medical marijuana. I'll tell my wife.
You don't need propranolol. You just need a Valium suppository.
All jokes aside, it works. Okay.
What about curry? We're in South Asia. What about curry? Does that make us go to the bathroom more?
Spicy foods can for some people. I think it's so variable. The data is
I have
really
an uncle that just
that
eats
strong.
jalapenos. Like he goes.
Who?
I have an uncle that just eats jalapenos, like
Oh
Indian jalapeno, like
mirchi. The mirchis, yeah. Oh my God, my dad eats that. I mean, it's nuts. I'm like,
is he always in the bathroom?
And it's like they're raw. They're not even cooked. They're straight up raw.
Guys, I eat those.
Rena, how's your bladder feeling?
My bladder feels great because I never pee. And so I've lost sensation in my bladder. Do not listen to me about how to manage your bladder.
We're like the biggest hypocrites, right? Like I got a kidney stone and I'm watching it, even though I'm supposed to take care of these things. But please, can you edit that out? What I just told you?
It's live, dude.
As my mom says, do as I say, not as I do. I can say it in Gujarati, but I won't freak people out on these things.
All right, guys, I want to give our live audience a chance to ask questions. Please put them in the chat if you guys have questions, or just say hi. Let us know how you liked it, because we really want to know. And we can keep talking about how we take care of our bladders poorly.
I see someone said THC, old police ears perked up. Like I don't think you can get arrested for if you have a license or you're just doing the CBD stuff, right? So,
well, no, it's medical marijuana. First of all, we didn't say straight up THC from an unknown source. Disclaimer.
But it is legal recreationally in some states now.
New Jersey.
It is?
Colorado, right?
I think New York's going to be next on the list.
I think Florida is. I don't know.
Where are you guys seeing stuff on the chat? I guess I don't have access to it.
It's just go. It's on the YouTube.
It's on the YouTube.
Yeah.
All right. Well, it's been an hour, so I don't want to keep you guys here all night. Your kids are asleep. Mine are still awake because they don't sleep now. COVID.
I think mine is like trying to get on air. She's.
Bring her on.
You know, we made this song called "Listen to Your Bladder" a long time ago when when Z-Dog was huge and he's still huge, but making all these videos. We made our own video thinking we'd go viral, and we didn't.
Here's your platform, your opportunity.
Oh.
All right, guys. Well, thank you guys so much. Thank you to our YouTube audience. Please comment down below. Let us know what you liked, what you didn't like. We take all sorts of criticism, and I will come back on and answer questions if you guys have some in the chat or in the comments down below. Thank you guys so much for being on tonight.
Thank you. Thanks for having me.